This spring, our Colloquium series will emphasize aging-related research in patient-reported outcomes, biomarkers of aging, research methods on detecting typologies, trajectories, and transitions. Our first speaker will be Ken Moselle. And on technology and aging, the topic of today. I wanted to also mention that this series is hosted in partnership with the Department of Psychology, the Education and Training Unit of Population Data BC, the Island Health Research and Capacity Building Program, and the Integrative Analysis of Longitudinal Studies of Aging Research Network funded by NIH. Delighted to welcome and introduce our speaker today, Dr. Jeffrey Kaye. Jeff is Leighton Professor of Neurology and Biomedical Engineering at the Oregon Health and Science University. He is Director of the NIA Leighton Aging and Alzheimer's Disease Center, and also the Director of the NIA-funded ORCATECH, the Oregon Roybal Center on Aging and Technology. Dr. Kaye's research has focused over the past 2 decades on the question of why some individuals remain protected from dementia and functional decline at advanced ages, while others succumb much earlier. This work has relied on a number of approaches, ranging across the fields of genetics, neuroimaging, physiology, and continuous life activity monitoring, which we'll be hearing about today. Dr. Kaye is also a co-program director of the IALSA network at OHSU. He leads several longitudinal studies of aging, including the Oregon Brain Aging Study, the Intelligent Systems for Detection of Aging Changes, and the Ambient Independence Measures for Guiding Care Transition Studies, using ubiquitous, unobtrusive technologies for assessment of older adults in their homes to detect changes signaling imminent functional decline. Jeff serves on many national, international review boards, international panels, and most notably, and recently, as chair of the International Society to Advance Alzheimer's Research and Treatment. And it was through his encouragement that we've submitted a PIA, Professional Interest Area, on research methods focused on reproducible research. So this is something that, if you're interested, please let me know. Jeff, delighted you're here. Thank you so much for coming.
It's a pleasure to be here, and I really am looking forward to this presentation and your feedback and subsequent discussions throughout the day. I love Victoria. I've actually been here quite a few times. Some of you have even heard, this maybe it's a little too personal, but I even think my daughter was conceived in Victoria. I don't have the technology to confirm that directly, but we think so. Anyway, okay, this has come up here. So what I hope to cover this morning is 4 things. And the first is actually, by way of background, some comments about the current status of clinical assessment, some of the shortcomings, and then using that as background, essentially how we might be able to improve the assessment using some of these technologies that I'll be describing subsequently. Ultimately, we want to look at the data, the evidence, what kind of data can you collect, what does it tell you? And then finally, I'm going to end with some examples of how one might be able to develop applications and interventions. So to start, as a clinician, there's really been very little change in the way that we assess people in the healthcare sphere. The basic clinic-based, office-based kind of approach has been the mainstay, the backbone of the way that we assess people. And the real challenge that I would identify or suggest is that really our challenge is to detect change. Really what's important, if you're starting out healthy, then if you never change, then we don't need a health system to help you when you're not healthy anymore, or I guess we might need it to prevent you from becoming less healthy. But in general, detecting that change is key. And the nature of change in health is very tricky or difficult because many changes are rather slow and they have a time sequence that is hard to detect as an individual. And then some of that change can be unpredictable but acute. And so you're kind of looking at multiple timescales of change that can be very difficult and challenging to detect. There are a number of limitations of the current approach, not the least of which is we rely on this kind of episodic, sparsely spaced assessment. And this is true whether it's in person or even phone-based or clinic-based. Those assessments are not determined really by the convenience of the person having the assessment, but more by the assessors. So we don't actually assess people on weekends or holidays, at least not in the U.S. And we don't know a lot about people's health during those time periods, as it turns out. Much of the assessment depends on a person's self-report, the recall of events as they perceive them happening. And there's a lot of data that shows, and I'll just give a couple brief examples in a moment, how misleading or inaccurate that can be. And the time to do these assessments is very limited as well. In the U.S., the average primary care appointment is about 15 minutes or so. So it's amazing that anything actually gets accomplished, and just speaks to the fact that people probably get better mostly on their own anyway. The assessment paradigms are not, they're artificial in the sense that they're not things that you typically would do in your everyday life, particularly in the mental health and cognitive realm. I don't know about you, but I don't sit around memorizing lists of words or doing tasks that are not everyday real-world tasks. And because of that, these assessments lack ecological validity. They're really not what people are doing in their everyday life. And because of that, we can't track how things are changing across the course of an illness in any real continuous way. Inherently, much of this assessment has high variability, either based on the rater or the actual tests. And then finally, the thing that I think is really important, and we're most behind the times in a way about, is we really have limited ability to connect how one factor in that person's life might affect what we're seeing when the person is in front of you. So we don't know much about how that person slept the night before, what they ate, what kind of interaction they had with their family, in the waiting room even, let alone the night before they were going for the study or for their assessment. So there are lots of challenges. By way of just a couple of examples, this issue of self-report inaccuracy. So this is a study that was done and completed recently. It was just accepted for publication by my colleague Kathy Wild. And I'll show you some of this technology later, but just to point out that in this particular study, we took people who had a sensing system in their home, which again I will describe in more detail later, and simply asked them to tell us, to record online what they were doing in the last 2 hours. And because we had the actual data in terms of where they were, and we have algorithms that tell us what some of these activities are likely to be, we found that about a quarter had no match with what they said they were doing. So they would say, I went to the gym, or I was in the kitchen cooking, or this or that, and there was just no match. So you can imagine that if you're in a clinical situation and you're asking people 1,000 questions about, are you exercising, and are you eating this, and are you taking this medication, a large amount of that is, the person's not lying, it's just hard to really remember. Another large group, actually had what we called a partial agreement. And actually, only 25% had a really exact match in this study. Another example, which gets at just one of these factors of the difficulty of the current kind of assessments, is this issue of accounting for effects that might, outside of the assessment encounter, that could affect the results that you're seeing during that encounter. So in this study by Adri Seeley, who's a postdoc in our group, she took the sensor data, which we get, that tells us something about their sleep activity. Again, I'll describe this in more detail subsequently, where we can get some measures such as the total time they sleep, some measures of restlessness in bed, and the time up at night, and looked at how the results of those metrics the night prior to taking a neuropsychological exam, the week prior, and then the month prior might actually affect the outcome of the results. And the bottom line is that actually, yes, how you slept the day before or the week before certainly does affect the results of those cognitive tests. And in fact, it affects it enough that it could make the difference between you're saying a person has mild cognitive impairment or not. So there's more than a standard deviation effect in this that disturbed sleep might have. So I think I've hopefully convinced you that there are some limitations. And this is a cartoon that I use a lot to kind of conceptualize the sort of basic principle of this change detection difficulty. So if you think about the way that things roll out over time, so usually we have a baseline measure and then some subsequently, annual assessments, for example, if you're doing long-term follow-up of somebody, and then a measure. And the measure could be a physiologic measure like blood pressure. It could be a cognitive measure like a memory test score. It could be a functional measure like a walking speed. Whatever that measure is, we tend to get these data points that are sort of somewhat sparsely spaced and variable. And then we decide that, well, there must be some relationship. And so in this case, maybe they're getting worse. Just draw a regression line. We then make it more complicated because we love the mainframe health system loves technology too. So we have to do a test when something pops out as looking aberrant. So this is a PET scan, sort of a $5,000 test. And then you say, well, still, how do we know that is that related to that measure or not? It's a one-time test. Or it could be even more complicated because there's symptoms reported before then. And is that symptom telling us something about the next data point or not? So we're really challenged to make sense of this sparse data. But imagine if you had data that applied to the time series that was every day, that was continuous. And so in this case, you would see that there's no change in the mean. Essentially, you caught people on the good days and bad days. But if you look closely, the real change is a change in variability, which you could never actually capture unless you had more frequent measurement. And that, in many instances, may be a great opportunity for early detection of meaningful change. So that's some of the major underlying principles behind why the more continuous approach is we think, of great value. So how would you institute this kind of approach? And so that's going to be, obviously, because you know the title of my talk, where I'm going to go with this. So the idea is to take the current paradigm, this kind of brief, episodic, clinic-based, obtrusive, inconvenient. Can you think of any more negative descriptions? and move this over to a more real-time, continuous, home-based, unobtrusive, ambient. I like the term ambient. It feels good. And a way forward of getting there is to take advantage of technologies that exist, actually have existed for some time now, and those lie in pervasive computing, computing everywhere, if you will, embedded computing, wireless technologies for particularly important for communication, and what's now become a bit of a buzzword, but big data analytics, because one does generate a lot of data, and there's a lot of important need to intelligently analyze this data to make sense of it. So if one can do that, we would hope that we would achieve optimal health. But from a research point of view, I think there's a tremendous opportunity for actual new observations and discoveries. There's kind of like a basic science of human activity and behavior that we will, I think, continue to evolve and learn about that we don't actually know much about. And there's a huge opportunity space just in that alone. At the same time, the way that we do research, I believe, will change because of the opportunity to get more ecologically valid and objective types of data. And then for those who are concerned about development, commercialization, businesses, there's a whole new world of opportunity in that space as well. So in order to do this kind of work, to make this kind of change, about 2004, actually beginning in 2001, there was a group of us got together to sort of think about how we might do this transformation, if you will. And we began to create a research infrastructure which became subsequently ORCATECH to do this kind of work. And so there are really four components to this infrastructure that are key. And it took us a lot of time to put this together, and it's always a work in progress. But the most important part is really the people, not the technology. So I think none of you have heard me say this because it's an easy phrase to say, but technology is easy, people are hard. And so understanding the stakeholders, and when I say stakeholders, it's the people that you're trying to help, it's the care community, whether that's professional or unpaid or lay care. It's the researchers. I mean, actually, researchers are hard. They come from all different stripes and backgrounds, and so really understanding each of those points of view when you're trying to answer research questions using technology is really the first step. So what we have done is create a number of ways of doing this. There's some traditional ways, are focus groups and survey kinds of research, but also more recently we've now are creating a research, we call it research over internet, ROI, the king. And this is a cohort that allows us to quickly gather information that's not available readily, that you need to have available when you're trying to deploy and design systems rapidly, or as rapidly as you can. So the cartoon there is just a snapshot of a survey that was done online of telephone use, different kinds of telephone use in an aging population. And there are some surveys like this, but not that many that are available that get you the granularity and detail that you need. And there are lots of instances of this that come up, right? We're going to be embarking on a similar kind of survey for bed use. So, if you want to look at nighttime activity, bed activity, I mean, how many people here sleep in a Harvard frame bed? Most of you don't probably even know what that might be. A metal frame bed. How many, now I get too personal, how many people sleep alone? You don't have to answer that. But if you're trying to design systems and figure out, what's going to work, it's really helpful to know that ahead of time, because you can design a beautiful, sensors, pressure mats, load cells, there's all sorts of ways. But when you go to deploy that in the field to answer some simple question about nighttime behavior or sleep behavior, you're cooked. So you have great technology, you're all dressed up, but nowhere to go. So that's a very important part of the kind of infrastructure. The second part is actually testing and understanding the technology and the techniques. So for this, like many universities, we've been fortunate. We have, in our university, we call it the point of care lab. It's basically a smart apartment. And this is a place where we can take devices, technology, systems, and deploy them in a mock apartment and test their various technical aspects of the system. And so this is where we find out how graduate students work or don't using the technology, which obviously clearly affects the real world. So graduate students are a valid and important part of our society, and we want to know about them in great detail. That's right. But once one learns about those, the use of technology in that space, what we do know is it never works as you think it would in the lab. And so the thing that we have spent a lot of time is developing what we call the Life Lab. And this is basically the smart apartment laboratory brought out into the community, where we have seniors who have volunteered to have the platform of technology, which I'll show you in a moment, installed in their home, turned on, and their agreement is you just live your life, except for one thing I'll tell you about that is a different, we do ask them to do that's beyond just living their life. But this has become an extremely important and valuable component of trying to understand how these kinds of technologies can be helpful. And then the last element is certainly not the least. That's understanding the data. So you can generate an awful lot of wonderful data, but you have to know how to interpret it, manage it, and make proper use of it. So the platform that I just referred to is worth also describing. So I want to first say that what we do is not, we are not in the hardware development business. We leave that to better minds, to the Vigils of the world and other companies. We're technology agnostic. So for us, we want to be able to put together systems that give us the features that provide the best data and practically so that we can do it in a reasonable lifetime in the real world. So the basic features and technologies are arrayed on this diagram. This is obviously an apartment layout or home layout. We use a lot of passive IR motion sensors. We currently are using these Zigbee IR sensors, which tell us a lot about just total activity. We arrange them in an array. I'll show you subsequently some more detail of some of these items to get walking speed and location. So activity by location is actually a really important feature. We are certainly interested in physiologic measures. There's lots of devices. This is, classic telemedicine has been around for decades. So being able to, get things like weight and pulse and blood pressure and things like that is a part of the system. Medication adherence is something that's very important for health care in general. We built this device years ago called a med tracker, which is just a plastic pill box where the lid is instrumented. So when the lid is open on that particular day, it records the time of day. I'll describe that in a little more detail, or its use in a little more detail subsequently. We monitor phones. We don't listen to phone calls. We leave that to our NSA. But we do monitor phone use, so how much time an individual spends on the phone. And under certain studies, consent, we will also get to a level of whether this is a personal call or not. So there are different ways to do this, but it turns out to be a very important and useful metric. Obviously, getting in and out of the house is important, or getting in and out of the refrigerator. So there's lots of doors that are useful to monitor. And then the last area that's called out here is computer activity. So this is the one area that we are obtrusive about. And the not so dirty little secret in this field is that you cannot, I don't think, so this is my bias, I don't think that you can build algorithms that are really good without some annotation of data that is self-report. So, you know, I went through this whole thing where I was like, oh, self-report's terrible. But there's some things that are internal states that we need to know. So does a person, are they depressed? Are they down and feeling blue? Are they in pain? You know, so these are, you know, you can look at outcomes that you think are related to that, but ultimately the person has to report them. And then there's some basic information that things like, did you move your furniture around? So if you're tracking how people are moving in a space, and how, so here's a good one for you. How often do you think people who are 75 or older rearrange their furniture, at least in the U.S. or at least in Portland, Oregon metro area? Infrequently. That's kind of non-committal.
Once a year.
Well, so 40% will actually move at least once a year. You know, and you know, move it's like a couch or enough that they actually could change the actual typical pattern. And I was surprised. I just like most people say like, you know, typical older person, they don't change, they don't. But actually, that seems to be the case. So those are questions that we ask. So we spent a lot of time trying to figure out how to be least disruptive to get that information. And what we have been doing based on kind of trying to window the burden, you know, time, amount, and frequency of question, we once a week push to them by a online interface a 13-item questionnaire that takes, on average, 4.2 minutes, and it has to be less than 5 minutes. So there's always this feature creep of wanting more questions, but we leave it there. So that's computer activity. But the other thing that computer activity is very helpful for, it actually tells us something about their cognitive function. So we can monitor their time on the computer, and I'll show you again later, mouse movements. A lot of things are available to us in the background to understand how they're thinking. And then the other critical box here is this device sensor X. So we set up the system so we can plug in other systems or devices of interest for particular testing or studies. Then this is all scaled out into the community, and then the data comes back to us through a secure internet connection. The system, this is just another sort of view of looking at this in a different way, but I like to show this for one reason, and it also kind of emphasizes, so the sort of components. So these are all sensors. One of the important pieces is there are different kinds of communication protocols, you know, Wi-Fi, 3G, Bluetooth. We need to use all of these or be able to use all of these because we want to be able to take the best of what's out there. And then we aggregate this into a local computer, a plug computer in the home. I'm not going to go into obviously all the details, but the other thing I want to point out is this is the back end. And there's a lot of work that has to go in the back end, and that's particularly important for doing this kind of remote monitoring where you don't want to have to send people out every, I was talking to somebody about this as a walk, we were talking about it a little bit on the walk over, you know, every few days the person has to go to each home to fix something. So being able to remotely upgrade software, determine if batteries in a particular sensor in a particular home is down, that is all part of the system. And it's a very critical part of being able to do this. And then the last sort of element that, again, I want to emphasize, but without going into too much detail, is the data itself. So building these algorithms or inference engines or whatever you want to call them, going from the raw sensor data to some inferred outcome is a science unto itself. And there's dozens, hundreds probably of ways of taking this data and building models and aggregating it. But so I just want to say that because it is important. But I also want to talk about the data. What do you get? What does it look like? And so one way to get there is to look at it, is to show you just some raw data from a single individual. So this is a spiral plot. We like these spiral plots as a sort of a data display tool. So what this is a 24-hour clock. Midnight is at the top, noon is at the bottom. In this case, each concentric circle going out is at a 2-week period. You can set this obviously at any interval. The colors represent where the activity, so this is total activity occurred. And in this case, we put these little daggers on, which is when this person had a computer session. So the first thing you'll notice is there's a certain regularity. These are actually pretty unique to individuals. They're like activity fingerprints. People typically have a time that they go to sleep. In this case, this person lives in a retirement community, paid for his meals, so gets up like clockwork. The other thing that those who are under 50 will be surprised at is how often a person gets up to go to the bathroom at night, which is normal in that age group. You'll also notice there's a discontinuity here, and that represents a change. And so that change in this case is because this person lived in a retirement community that had a norovirus epidemic. So norovirus is a gastrointestinal bug that is contagious. It's actually most common in child care centers and congregate housing, nursing homes in older adults. And it can be actually quite, it's very unpleasant. It actually can be, people can get quite dehydrated and sick from it. So in this case, we knew that this was running through the community, and we had a fairly large installation of homes in this particular community with the sensor system. So we asked the question, could we detect without them self-reporting who got the virus? And there were a lot of ideas about how to do that, and simple is always better. So it turned out that just by looking at changes in room transitions was remarkably effective at detecting the people that developed the virus. It was interesting that a lot of the, it doesn't sound like I pick on graduate students, a lot of the graduate students had these great, rather elaborate models about all these factors that would go in and predict, but it turned out actually that we actually didn't need a very complex model to predict this. So this is just an entree or introduction into the kinds of things that and kinds of data one can get. Another example is looking at walking. So walking and walking speed in geriatrics, some people have called it the sixth vital sign. It's been shown in large epidemiologic studies and cohort studies that just measuring walking speed with a stopwatch predicts all kinds of morbidity and mortality. But it's pretty gross data. It's usually measured with a stopwatch. So this is a typical, what you see is, a measurement here, like the opening, like that cartoon I showed you. Is this person getting better? We don't know. This is actually 2007, 2009. This is an old slide, but imagine then if you actually use this sensor line that we use. So every time the person walks under this line, this is what there's no cameras. This is just what the field of view of the sensors are. You get a walk recorded. And so this is what walking looks like in that situation. It's a population of walks, and you get hundreds of walks in a week. And you realize that then there are perhaps just a mean number. You can look at fast walks and slow walks. You know where the person has walked from or to. So fast walks are typically to the bathroom or to answer the door and things like that. And just because this comes up when I give these presentations, we have tried to verify this with gait maps, and we really know that these are walks and not just random noise. Similarly, in terms of activity, so now that you know all about spiral plots, so here's a couple of spiral plots. This is one individual. So this, again, looks like a typical plot. And this is an individual who is in the Life Lab back in 2011 and doing quite well. And then you'll notice here something changed. And now they're going to sleep earlier. They're up a lot more, moving around at night. They're getting up early. There's not as much activity during the day. And what happened is this individual developed Parkinson's disease. And I just point this out because this is about Parkinson's disease. One of the cardinal features is a difficulty with mobility and walking. So here what you see is initially this is the walking speed over time. And so it goes from January 2011 to September 2013 in this diagram. These are the age-matched controls. These dots are the walking speed of this individual in red, who's the person who developed Parkinson's disease, measured with a stopwatch in person. So people always walk faster when they're being observed. So it's very typical that a patient will come to clinic and they'll just have them walk, and then the family will say, "I never walk like that." So that's what this really shows. But what you see here is first there's this sort of increased variability, and then it just slowly declines. And then the diagnosis was made by a clinician of Parkinson's disease. And then actually the standard therapy was applied. It didn't work so well, and then the dose was increased. And this is actually, there's some other data here. But the point is that you can see this change quite a ways before the individual actually developed Parkinson's. And the other interesting thing is you can actually see these rather small but clear changes in the treatment in this individual. Other examples of the kinds of data that one can look at, I talked about the medication taking. So this is the med tracker. It's like a high school science experiment. It could be done a lot more elegantly, but that's what it looks like. These switches, by the way, does anybody remember floppy drives? So these are actually the same switches that were used as floppy drives, and so we could get them incredibly cheap because nobody uses them anymore. And it turns out that they were designed for thousands of repeated uses. So actually, it served us well. And this is just some med tracker data. This is the morning dose, evening dose. Typically, people are always worse with the afternoon dose. And then you see these dips. And what do you think those represent? This is just a percent adherence. So those are holidays. And this gets back to the, what I was saying about, we don't assess people over those time periods. And this allows us to look at, there's actually many metrics one can look at. So here's just another way of looking at this kind of data. This is twice-a-day dosing of a medication, and each, so you can have a typical time or a planned dose time, which is this line. You can set a dose window that you think people should be able to achieve. Obviously, when the compartment's open, you take that as evidence that there's some kind of adherence. And the X's are missed doses, and then this is an out-of-time dose, of course. So there are actually lots of metrics that are inherent in just being able to get this data. But can you actually detect any change in the person's function? And so this was an early study done by my late colleague, actually, Tamar Hayes, looking at using this device as a proxy for decline, or not decline, but for cognitive function. And so in this study, people were asked to take a vitamin twice a day, which is not a normal paradigm, but we did that because we couldn't ask them to take Lasix if they don't take it, but we wanted everybody to be on the same regimen. So that's why we did this. These were people all living independently, not demented, but they were tested with this scale called the ADAS-Cog, which is used in clinical trials for Alzheimer's disease, and simply divided pretty much by a median split into a luck of the draw, higher cognition, lower cognition group. And if you look at those two groups, those who were in the higher cognition group were very adherent. 80% is typically used in clinical trials as being the gold standard. You could actually get the real time. They were actually pretty good at within a 12-minute time of their goal. But in this group on the lower half of the draw, they actually didn't meet it. So you can imagine if you roll a bunch of people in a clinical study, or you have a patient who has just, again, these are living independent folk, they might be quite challenged to keep up with their medication taking. All right, I have just a few more of these examples. Now this leads us to other features of cognitive decline. And going back to the motion mobility issue, and this came up, I put this in we were talking about this earlier this morning. Total activity and walking speed have now been shown, not just by us, but others, to be a marker of early dementia or mild cognitive impairment, a precursor syndrome to dementia, particularly if it's memory loss, it's particularly a precursor to Alzheimer's disease. And what this simply shows, in this case, it's looking at the variability or variance in activity, total activity levels, just looking at different time windows across a day averaged. And so this is a small study over 315 days. And you see that the mild cognitive impairment group consistently is always has higher variability. And I don't show it here, but also the total activity and just mean walking speed are significantly different. This is also done in a separate study with my colleague Hiroko Dodge, and just showing that there are, in a typical older population, it's always nice when it's the law of thirds, they kind of shake out to be fast walkers, moderate walkers, and slow walkers. But then what we thought to do was to say, well, if we have this population, in which group do the mild cognitive impairment people live? And it turns out that vast majority of these individuals are in this slow walking and declining group. And getting back to this issue of variability, so looking at variability, there seem to be 4 variability groups predicted in this, and this is just using the coefficient of variation of walking as a variability measure. So there's a high variability and then declining, and then these 2 middle groups, and this sort of low and declining. And as it turns out, this group is populated by early MCI and late MCI. So we think actually people are starting out with high variability and decline. Actually, you pass through these stages, and then ultimately, there's where you end up. There are other sensitive measures of cognitive decline, early cognitive decline. So looking at mild cognitive impairment and computer use. So this is, again, just time on the computer. It's not actual. We're not looking at the content or anything. We see this clear difference in age-matched control group compared to the MCI group over months of continuous monitoring. In this case, this is the mean days on the computer, but also when they're in a session, a computer session, they use it, the sessions are shorter. And back to that theme of variability, the pattern of variability in use day to day or week to week, either one, is significantly different in the 2 groups. So this actually turns out in many of our analyses to be one of the most sensitive measures. And then finally, sleep or sleep behavior. So this is not polysomnography. We don't think. Has anybody ever had a and this is again personal question, but polysomnography where you have all the electrodes on your head and you're asked to sleep in a laboratory, right? And it's a wonderful night's sleep. Obviously represents your real sleep, right? So this is using this passive sensing, and we get a number of measures, and this has been verified using the more conventional methods. But here's two measures: wake after sleep onset. So when you go to sleep, there's a normal time that it's like your first awakening. You're not aware of it. You can't really accurately self-report it. But that's what we're measuring here. And so the MCI groups, so this is amnestic MCI, non-amnestic. We divided them, in this case, into these two groups. We could lump them if we wanted to. And this is just times up at night. So there were clear differences in these metrics, sleep metrics as well. So in terms of that's sort of ending up this tour of kinds of data, and then I want to end with some applications. I do want to just briefly touch on the self-report business because it is really important. So in this case, there's that question that we ask every week, which is actually during the last week. Actually, I think this would be past week. Have you felt downhearted or blue for more than 3 days? And again, there's a long history of how we arose at this question. But this is the kind of pattern that you'll see over many months of time. In this case, it's actually 2 years, 24 months. And what this shows is what we see in the Pacific Northwest, sort of seasonal fluctuation in mood. And this is not major depression. This is just low-level mood change. We've gone on, and this is data published by my colleague Stephen Thielke, who's at the University of Washington. There's a theory about psychomotor slowing and depression. Well, because this population does actually not have fortunately large numbers of people with major depression. They have low mood and variable but low. So in this case, they were asked that question every week. 2.6% involved low mood. So a very small number. But out of that, because we have all this data continuously over time, we were able to ask the question if motor speed, such as walking speed or room transitions, actual physical movement, was related to this low mood. And it was not. It would seem to be what might be considered the more either cognitive or social measures, so time out of residence or computer use, that were related to this low mood on a week-by-week basis. So I've presented a lot of sort of tours of the kinds of data, some evidence of how it affects or is related to various health states or cognitive states. And now I want to just end by talking about some of the applications and interventions and ways of going about evaluating this kind of technology and systems. And some of this I changed at the last minute because of some wonderful conversations I've had since I've gotten here. So I was thinking about now maybe it's a little disjointed, but you'll forgive me, I hope. So there's all sorts of ideas about how to use this technology in the real world. And those of us who don't have much on top don't want people Earth looking down at us. So one thing that is very important is in developing using these kinds of technologies is whether people actually accept and use things. And so it's clear that in most surveys that we've done and others have done, people don't want cameras in their home, particularly in their private spaces. However, because we have this Life Lab, we are approached by various companies and also academic groups to test out various approaches. And so this was just an example where we were approached to test this telepresence robot by the Vigo company, which is located in New England. So it's actually industrial design. I don't know. It's actually kind of nice. But you can drive this around remotely. So the adult child can actually move this thing around and spy on their, you can call it spying, on their parent. But the parent has to consent to that. And I have to say, when I was approached about this, I said, really? But we said, okay, well, let's research, let's do it. And it turns out that this is a two-way system. So there's actually seeing the person's relative seemed to be a very valued visualization. And so these are just some of the comments. This was a small study. There were only a dozen people involved. But, so the majority of people were actually remarkably positive about it. There were some negative users, but most of them were positive. And then the remote user, these were mostly the adult children, actually really liked this a lot. The company is sort of developing it. I think it's like $5,000 or $6,000. So you could probably get in-home help frequently for that amount of money, although I guess over time it might pay off if you have a long tail. But this is just an example of development, application, and the kinds of things that we are doing with the Life Lab. So one of the things that also is important in terms of developing and applying the data is what I call putting it all together. So you've probably noticed that most of what I presented as examples were really single functions: walking speed, computer use, sleep. But really the value I think a lot of us feel about this data is actually being able to use all the data and make these prediction models, for example. And so this is a cartoon or a conceptualization of that, and there are lots of different aspects. And so we've been trying to put these all into all these aspects into the model, and and even including daily weather data. It turns out the weather outside affects your activity inside, not simply that you don't go outside. The consumer price index is a measure of happiness or not. So there's a lot of data that one can put into these models and then look at important outcomes like care transition, because clearly each of these is different for each individual. And this brings me to this project that we're doing where we're trying to build these models to be able to guide care transitions better, and ultimately to prevent I don't want to use the term unwarranted, because it's it's in the eyes of different beholders, but to try to make better informed decisions about care transitions and ultimately try to reduce them if possible. And so there's three aims. One was just to sort of summarize this. One is to actually develop them, develop the system, and so that was really a lot of what I showed you earlier. We have tuned that system for this project, and now we've just completed a process of developing the system to interact with the care community. So the dashboards and the data that they're presented in, and that's a lot of effort, because there are different, lots of different constituencies and lots of different levels of experience and knowledge. So we've done this iterative process there, and I think I'll show you just a sort of an example of that. And then finally, we're planning this spring, early spring, to deploy the system and do a randomized study. Randomized, that is, from usual care versus what might be called informed care, using these measures. And so this is what you wouldn't do, but I show it actually because it's a great example of a bad design. So this is a dashboard that a student came up with. God, I must sound like I pick on students. A very bright student. who likes this color palette. These are the just subject. So looking at displays, and so this is environmental variables and home types of activities, where a person is and they're walking, and their physiologic measures and their self-report measures and sleep and socialization. So, and whether the only thing that gets reported here is if there's a change. So it's an interesting way to look at things. And then, drilling down, one can look at more specific features. So this is another visualization that came up and has been actually reviewed by care teams. It was surprisingly more accepted than I thought. So these are actually time-based activities, time in the kitchen. So you can kind of move this bar along and get the actual readout. You can click on these and layer in different, so time in kitchen, time in bedroom, time in bathroom, and look at these changes over time. And so I just showing this because this is part of that development and the way to get to a potential display of hierarchies of displaying data and providing data in ways that people might or might not want to see it. But the bottom line is, ultimately, can we predict these transitions? Can we use all this data? And so we have built a model based on old data from another longitudinal study called the ISAC study. So we didn't have all this data. We didn't have the med tracking data, some of the physiologic data. But using that model, this is work with Dan Austin, who's a new faculty member in our group. We actually, this is data that's too good to be true. So this is, we'll see if this pans out. But we, using essentially a set of 34 behavioral activity metrics, and I think there were 66 million data points in a subset of the, well, not a subset, in this cohort, which is about 103 people. We were pretty good at least in the sensitivity analysis, at predicting care transition within 6 months, within the next 6 months. So we'll see how that goes. The other thing I want to point out is that there's this opportunity to take the same data and look at other interesting features. So using the same data set, this was some work actually we did with for Eli Lilly. Remember I mentioned about this pain question? So there was this interest in looking at pain and drugs that people might be taking. So we've collected this pain and drug data in the same cohort, and then we wanted to see if there was a behavioral pattern that predicted drug class. And so what you're looking at here in this spider plot, my son likes Spider-Man, so I like the plot, these are the odds, based on being on no drug, no NSAID or opioid. And you can see that there's these interesting patterns of based on computer use and some of these other behavioral metrics that seem to describe being on one or both of or none of these medications. So just again, this is an interesting added value you get once you have the data, so you can use these other cuts of the data. And then finally, I'm going to end with this intervention study that was completed. This is a study that Hiroko Dodge, her R01 study, where the idea was to use some of this technology, the in-home technology, to decrease social isolation by increasing the dose of social engagement. So there's no pill yet you can take to increase your socialization yet, although marijuana is now legal in Oregon. So we'll see about that. But this study was designed to use video chats, essentially. So this is a You can actually see the smile. This gives it away. This is the mom, this is the daughter, and this is the granddaughter. This is a sticker. It's not a dermatologic condition. And so these chats were designed. So first of all, I'm amazed that this was actually funded, to be honest with you, because most people say, like, you're going to get people 4 times a week for 6 weeks to just every day have a chat with a trained conversationalist. It's basically an RA. And so the way this works is that these were computers that were not, the person did not have to know how to use a computer. So this was a dumb computer terminal, if you will, that was designed to ring on its own, and then the person would touch the screen, and it would bring up this is our Maddie, one of our highly loved conversationalists. And they would have a conversation each day. And it was interesting that when this study was designed, it was thought that maybe the conversation would lag. So there's this whole book of possible topics to stimulate the conversation. So and the person could bring up a stimulus picture. So this is like an example of one of those. It turns out that there really was not that much need to do that. That most of these older folks just wanted to talk. And so this, I've been doing intervention research, clinical trials, pharmacologic studies for a long time, for decades. This study had the best, there was no dropout. It was the most highly loved study that I've ever been involved with. The people actually, when Maddie, for example, got sick for a couple of days, they actually called in to ask if she was okay. So it really, I mean, it's really, people are very much isolated and want to be engaged. So the results, this has just been accepted for publication. You know, honestly, it's more of a feasibility study than anything at this point, but, and that was clear. It's entirely feasible. You know, 89% of all the sessions were completed. There was no dropout. And there was a signal that there was some improvement on at least some of the executive fluency tasks. We've also been analyzing the conversations, again, not the content. Well, actually, yes, the content, because we do this, we can anonymize it to groups. So we've found that the MCI, people with MCI actually seem to talk more. We're also looking at turn taking, and there's other aspects of the conversation that one can analyze because you have the digitized audio file. And this brings us to what now is going to, I think, explode, certainly in the US, and this is direct-to-home video visits. So conducting your office visit direct to home. It makes complete sense, I think, and we're moving forward and very aggressively in this area because it's got to be what's got to be. We've done some work with these kind of interfaces through the Alzheimer's Disease Cooperative Study Project years ago. This is just a picture of a kiosk that was designed by us and used in that study. But you know, basically, you can have, this is actually a dumb video or smart video, excuse me. But it's not live. So this is a simulation, if you will, but this person, Jessica, she lives in Colorado now, takes the person through the exam, and then you can record the aspects of the exam. But you can now imagine that we can do this now in real time. And the software exists, it's secure, and this is something that we'll see a lot. The reimbursement systems in the U.S. are glacially but perceptibly actually going to pay for this. So there's going to be a huge sea change. The other interesting aspects of this is that once you have the audio data, you can, in the background, this is a category fluency test, you can actually automatically get the results. And so I don't have to sit there and write the results, it's just you get it. And you get even better results because you can look at the timing, you can look at the non-words and all sorts of things that are very hard to measure in the conventional interaction. And then really cool for the near future is you can analyze a person's facial expression. Are they depressed? Are they engaged? And so this, I think, is going to be a big deal. And we're very excited about this aspect of using technology in healthcare. And in Oregon, we recently got a grant from the Centers for Medicaid Medicare Innovation Program to develop this interface. The last day, this is my last pitch, and that is the value of using these kinds of approaches in the area of clinical trials. And the reason I believe very strongly about this is that the conduct of clinical trials, just like the conduct of medical interactions, clinical visits, hasn't changed since they were started. You know, we were discussing this, I think, at dinner. That I think it was James Lind was the British. Was he a physician? I don't know. He was a ship's physician, maybe. Conducted what some people call the first clinical trial, where he gave limes to what subsequently became the limeys. You know, but things that have not really changed all that much since then. Being able to actually capture data that's objective, continuous, has so many upsides. And I'm not going to go through all these because of the late hour here, all of these aspects. But I can show you this, that, you know, so for example, when we do a clinical trial and we take a baseline of somebody, so if it's somebody's walking speed in a Parkinson's study, or their cognitive testing, their memory tests, this is actually what the population sample looks like, right? Like this population A, controls versus the treatment group. But actually think about it in a different way. This is one subject, and another. So within a very quick period of time, you get the intra-individual's variability, so that you can really, the precision of the estimate of change in an individual becomes possible, whereas before it was not really possible. And if you do some simulations and kind of figure out the sample sizes you would need based on the old methodologies where the variability is so high and the precision of the estimates are so poor. So for example, in a typical prevention dementia trial where you use a delayed recall task, you know, to show the typical effect sizes that these studies are powered for is somewhere between 20 and 30%. So you'll have thousands of subjects who are enrolled for years to show a potential effect. If you use these continuous measures, you can see you can drastically reduce the sample sizes needed. So the implications of just the economics of doing trials, the fact you could actually you could test more drugs if you don't need as many people to be enrolled in a particular trial. So again, this is something that you know, maybe you'll invite me back in a few years and see if this pans out as being something that really happens. But I really think this is going to change the way that we do clinical trials, and I think that hopefully will drive the use of this kind of technology in general healthcare, because a lot of physicians are actually evidence-based. They do want to see, you know, where's the data, does it work? And so we need to see that penumbra effect, I think, of using these kind of measurements in clinical trials, and then hopefully that will move into more practice. I want to end by acknowledging a lot of people and places. So I'll point out that I presumptuously assume that we will be having lots of collaborations. We already have lots of collaborations, but I hope to see that even more so. There are lots of groups that we have worked with and hope to continue to work with. We very much appreciate the industry's needs and think that we should be working with industry. I think that sometimes in academia there's this kind of sense of it somehow makes you less worthy. You're going over to the dark side or something. But actually, I think that's totally wrong. And so we've been very fortunate to work with a lot of different companies in this space. And then last but absolutely not least, the funders. And in particular for us, the National Institute on Aging has been our mainstay. And, God bless the National Institute on Aging. So with that, I'll thank you all for staying awake and listening. And I guess there's some time for questions or comments and so forth. So thank you. Yes.
A practical question. How do you manage with the sensors, like the activity sensors, if there's two people?
I should just answer that question before it always gets asked. There are actually 5 questions that get asked. I'll see if all 5 of them do get asked, but that's one of them. So the simple answer is we have focused on people who live alone for 2 reasons. One is that, as it turns out, those are the people that are at most risk for bad outcomes. And at some level, you might argue need the less assistance because they're not living with it. If you're living with somebody, you need less assistance if you have a person who hopefully can help you. Having said that, the other reason is technical, is practical, that it is harder to differentiate using passive sensing one person from another. You can do it algorithmically, and we've done that and so forth, but you have to throw out a lot of data because it's ambiguous. And so for research, you can do it. You can get significant differences. But in a healthcare application where you need to know at a particular time, is this person different? That makes it much more difficult. So that's how we've approached a lot of this in just practical research. However, we are technology agnostic, and so we have been working very hard on some applications for essentially two-person homes. The 2 solutions that I think people have used, one is cameras. That for us is not, we don't believe that's the direction to go into. There's a minority party, I don't know if they're a minority party, we may be the minority party, but there's a party that believes the Kinect camera is a revolutionary tool that really is going to solve that problem using typically degraded images. So if you were to look at what the person sees, they're blobs. But in our surveys, youth surveys, most people say they don't want even that in their personal space, like their bedroom or their bathroom, because we were talking about, well, you can see these 2 blobs having sex. I still don't feel comfortable with that. And so it's cameras I don't think are going to be the solution. So that really leaves right now, within the next few years, I think there are actually some, that you can get that potentially differentiate Wi-Fi signal disruptions, and there's some other cool things you can do, probably more passively. But I think for right now, you're talking about wearables, and it's probably the wearable is something that's in a watch-like, wrist-like form factor. And I'll tease you with, I was hoping I would be able to present this today, but I just couldn't do it because I don't feel confident in the data yet. But I think we actually have a really, really good solution, which I'm extremely excited about, which actually does involve a wearable. So then there's trade-offs on that, of course. Yes?
I'm just wondering if you had looked at something like Biscuits. I wore one over the summer, and I found it was fascinating to look at sleep patterns, and also the sauntering when I really walk quickly, briskly. structured and that had other capabilities. I just thought, you know, it can be that you can have to power, all the rest of it, so, and then somebody would be going into the home to download it.
Right. So there's trade-offs, and so in the populations that we work with, first of all, it doesn't do any. It doesn't tell you the time. It doesn't. It's like a appliance or it's a jewelry or it has these issues of just as you say. You know, how do you get the data? Actually, for us, we need the raw data, so you know we have to either work with a company or jailbreak the back end to get the raw data. Some of most of these companies are not that friendly about things like that. So it has some limitations. And also, all fitness bands do not give you location in the home. So it's just, so you might as well just have a cheaper way to go is just to have actigraphy, just an actigraph, which is fine. And we've also tested a number of the fitness bands in a sleep lab, and I can tell you that I'm sure you feel better sleeping and knowing that it's telling you you're sleeping okay, but you'll get 5 different answers depending on which company's band you've bought, and I don't know what it means other than, it's highly homogenized data into some kind of readout that they're saying is good sleep, bad sleep. So it can be useful as a motivator. Probably, the longest standing motivator using any kind of wearable device that's proven is the 10,000 steps program. And that uses a $2 pedometer that, and it's based on the principle, you just kind of look at this thing, say, oh, I got to do more steps. And it doesn't really matter if it's, so it just depends, I think, on the application and what you're trying to get out of it. Yes?
I've got a question here from Andrew Smith, and he asks, in addition to clinical trials, do you see an application for individualized medicine? That is, do you envision titrating medication using continuous measures as a tool for deciding dose?
Yes.
What do you think, Andrew?
I think that's, the research needed to get to the point where you can make those kinds of predictions in real time for an individual. It's very much, the idea that you would, at home, so the future, at home, there's a pad and you put your finger on it and it extracts a micro dot of blood that you don't feel, and it extracts your DNA and it sequences your genome and it tells you all these things. And I assume that, maybe my great-grandchildren will hopefully have that benefit, and it's real. Actually, anything you can see, if I can conceive of that, then it's doable. So I think that is a future, and putting together the more objective activity behavior data, so the phenotype, quantitative phenotypes, with the biology, the other quantitative part of our phenotype, is the big win, and being able to individualize that data. So I think that is going to happen. Just it's the time horizon that's, I think, a big question. Yeah.
I was just wondering, we did sleep tracking using pressure mats.
Mm-hmm.
How do you do it using PIR sensors? Just focused on the bed, or?
Yeah. People move, or they don't, and they move. So some of it's really easy. Obviously, if they get up and they move out of their bed or in the bed. So some of it's actually quite easy. The algorithms for the restlessness and the wake after sleep onset are a little more tricky, but that's all passive. We also have used pressure mats. We have there's a great group that's using load cells and has a system of load cells under the supports of the bed, the frame of the bed. Actually, in many hospitals, one of the largest manufacturers of beds is the Stryker company. And in many of their beds, they actually have load cells, and they've been used simply for alarms of whether the patient's in or out of the bed. So incredibly, they're not really used for anything more than that. But there's lots more you can do with that. So Zach Beatty and Chad Hagen, they're sleep guys in our group. They have been working on that. And the load cells are interesting because you can get, when you're lying in bed and you breathe, you're actually going like this. You may not perceive that, but the load cells do. So you get respiratory rates, and then there's also a ballistic cardiogram that also can be generated, and so you can actually get respiration, heart rate, and these sleep measures passively using load cells, which I think is very interesting. So in the hospital environment, because these beds already have the sensors, we're doing that in a hospital setting, and then we're developing the algorithms from the hospital beds and using those with these load cells that we can deploy in the community. And we have a system now that it's a prototype that's it's like they're like rails. So you sort of this goes back to this whole thing about, well, what kind of beds do people sleep on and all that, and do they sleep alone or not? And it turns out, so of those of you who sleep with a partner, how can I say this without being too personal? How many of you sleep always on the same side of the bed? What's that? And how many of you move around all the time? Okay, so that's that's about right. So if you're doing, if you do this without taking pictures and trying to say, whose sleep is it and so forth, kind of have to work that out or know that. So technology's easy, people are hard.
What about if the dog gets on the bed?
Actually, yeah.
You thought of that.
Yeah. And dogs don't, you can tag dogs. They don't care. They don't have a say. And we don't have to get consent of the dog. So.
Jeff, thank you so much. Outstanding program of research, and thanks so much for sharing all this with us.
Well, it's a pleasure to be here, and I look forward to the rest of the day and evening talking to people and hopefully developing some cool collaborations. You have a great group of people up here. You're doing great things, and we'll see where it all takes us, hopefully. Thank you.